Hannon. How are you?
Hi, how are you? Thank
I'm
you
doing good.
so much for agreeing to this. Rabbi Harari, Rabbi Beta, listened to one of your interviews today.
Oh my goodness. Okay, great.
Yeah, okay. And Mrs. Sutton, thank you so much for doing this. Dr. Sutton, thank you.
Very exciting.
Okay. So besides her science class, there are 4 students joining from other classes that want to go into medicine.
Great.
So we're very proud of both of you. Renee in your grade, superstar, and Frida in her grade, superstar.
I don't know if I was a superstar, but
Yes, okay, superstar.
Oh, it's
Okay.
always fun to come back. I know that when I was in my master's program, when I would or maybe just in college, I would come back and come to visit at the high
Right.
school. You know,
Right.
because as a student, I always liked it when people came back.
Okay,
'Cause
are
it
we
gave me a couple minutes.
taping this so we can put it on? Yes? Okay. Okay, bye.
Bye, Miss Anna.
Okay.
I'm gonna wait another second just because I know that there are these other students that are supposed to come in and class just started, so they should be here any minute. Is everybody here today? 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. Who are we missing? Is Daniela here today? Norma's here. And what's Daniela's here today? I forgot. Oh, I think she's joining on Zoom. Oh, here we go. Stephen Bennett is joining. Dr. Gindi, what were you thinking in terms of timing? I know I left it pretty flexible.
I've got some slides that I thought we could walk through. I did not necessarily spend a whole lot. So I have some slides. We can stop and talk throughout. We can do questions at the end. All of those are fine.
Okay, sounds great. So most of our questions I'll be able to field because I'm in the classroom, but for Stephen or here we have other people joining, for anybody else that joins, just maybe speak up or write something in the chat and hopefully we will be able to see you.
Yeah, so the one thing that I will request, because I'll be presenting, it's a little hard for me to see the chat because I'm sharing my screen. So I would say Gila or Stephen, if you do have some questions, and Dr. Sutton in your class as well, if you do have some questions, I would say just jump in on the audio. That is absolutely fine with me.
Okay, great, thank you.
Okay, let me know when you'd like to get started and I will be ready.
I think we're ready. We don't want to waste
Okay.
time. Okay, yeah, so
Okay.
I'm have to enable you. There we go. So you should have screen sharing capabilities. Just let me know.
Okay. And are you able to see my screen at this point?
And I'm going to take something.
Okay. Okay. All right. And I know that we are recording, so hopefully this is where we will start. And it is my pleasure to be here to talk a little bit about the title of my talk is called "How Not to Fall Off the Cliff" or My Journey into Public Health. And the title will become a little bit more self-evident as we go on. My name is Renee Gindi, and I was a proud graduate of Yeshiva Flatbush Elementary School in 1991 and of the high school in 1995. My current title is the Chief of the Population Health Reporting and Dissemination Branch at the National Center for Health Statistics, which is part of the Centers for Disease Control and Prevention. If you haven't heard of the CDC before now, you have been living under a rock for the last 8 months. So I'm really glad to be here talking about my journey and my work. I will say in just a moment that this is the standard government disclaimer. The statements that I make in this presentation are my own and do not represent the views of the National Center for Health Statistics or the Centers for Disease Control and Prevention. I am not a coronavirus expert. If we decide that we are going to start talking about coronavirus or other things that I don't do research on, I will make sure to say at that time again that those are my own opinions as somebody with an infectious disease epidemiology training, but they are not going to represent the views of the CDC. I do want to mention that during the course of this talk, I will be pulling lots of slides and have lots of information that other people have worked on. And so I'm not going to list all of them here, but I do want to at least acknowledge that there are many other people and other organizations and NCHS that who have provided the reports and images that I use in this talk. So falling off the cliff. What I want to start with is this idea of the cliff analogy of public health. So for most of you, you may be in this room, you may be joining us today because you have an interest in medicine or biology. And so you probably are thinking about maybe being a doctor or working in the medical field, but not everybody is quite as familiar with the ideas behind public health. And so this analogy is actually just a little light way to be thinking about it. So this is, kind of drawn in a very sophisticated style, but let's walk through this graph together. So we're going to start with A. We are going to talk about levels of health intervention and the cliff of good health. So in part B, oh, look, we are a bunch of people and we have found a cliff. This looks interesting. Oh no, in part C, I'm going to start falling off the cliff. Woo, I'm falling in D and E. Boom, I've smashed and I've hit the ground. I may have a severe illness or injury at this point. What I need now is acute medical intervention to help perhaps save me from the severity of this illness or injury, which luckily here in part F, the ambulance has come to get me. And is maybe providing me with treatment or maybe providing me with some other mechanisms to make sure that I don't die of my severe injury. But what else could we do? I mean, that ambulance is really helpful to have to make sure that I don't, that my acute injury or illness doesn't get worse. What else could we do? Oh, I know, in part G over here, we could have a really great net. We can have a net that will catch us once we start falling over the side of the cliff and, maybe slows the fall a little bit. Maybe you don't smack the ground quite as hard. But at the same time, nets can have holes in them, or if lots of people fall off the cliff, then, the net can get overwhelmed, or maybe the net just won't work as well as we were hoping it would. Maybe it won't slow that spread or decrease the severity at all. So let's see, what else could we do? What else could we do? Oh, in H over here, we can actually build a fence. We could build a fence at the edge of the cliff. So that way, rather than hoping that the net will catch us or that the ambulance will save us once we've fallen, we're going to try to prevent those falls altogether. Okay? And then in I mean, so can we get any better than a fence? Well, actually, we may be able to get a little bit better than a fence. We can actually take people and move them back away from the fence, right? So maybe the people are up looking at the fence, kind of looking over like, wow, that looks really fun. I think I want to go see that cliff a little bit more closely. And they would fall anyway. So if we move them back, we can actually decrease their risks even further. So the reason that this cliff analogy is an analogy for public health is that, in fact, the falling off of the cliff is just a metaphor for illness and for injury. So when we've fallen, we've crashed into the ground, that's severe illness or injury. So think about it as a heart attack that has occurred, right? And so often when someone has a heart attack, they unfortunately they die of it. Now, what happens in F with this ambulance? That's acute medical treatment. Maybe that's an emergency surgery after a heart attack has already occurred. But what's happening in G with that net? Well, we are trying to maybe prevent, we're already starting down the path of falling into illness and injury, but we want to prevent the severe the consequences of disease. And so that net maybe is the ability to provide cholesterol medication or blood pressure medication when those metrics get too high. So what's the fence? The fence, and so the net was also very much about medical care, right? But the fence is where we really start to be talking about public health, right? So we're not just talking about a person who is getting sick, a person who is sick and how to treat them once they walk into a hospital or a doctor's office. We're talking about how to prevent people from getting sick in the first place. So that fence, that public health prevention for the heart attack could be something like making sure that people are eating well, getting enough exercise, not letting them get high cholesterol or high blood pressure in the first place. So then what's going on in I? What is this push back from the fence? Well, to a certain extent, the fence, where public health has been maybe for the last about 60, 70 years, is very focused on individual level behaviors, right? I am going to eat better. I am going to exercise. I am going to make sure that whatever the other public health measures are, that I can put into place in my own activity to decrease my risk of cardiovascular disease. But what happens if I live in a place where I live in a food desert? I don't have access to fresh fruits and vegetables, or I live in a place where I don't feel safe going out for a run after work. So I don't really have the ability. I don't have the structure is not in place for me to be able to engage in those individual preventive behaviors. So there's a certain amount of sort of societal pushing to impact social determinants of health that we see in I, and that is one of the areas where public health has been moving. It's one of the reasons why we, call it public health, right? These are not individual level decisions, but these are big structural public policy changes. And so that is really the cliff model of the cliff analogy for public health. And so I'm coming to you as a health statistician these days. That is technically my title. And so what are health statistics for? Why do we need them? Well, if we think about this model, we need to understand the numbers. We need to understand the statistics behind all of these different pieces in order to make decisions and to figure out how to spend our medical resources. We need to know how many people are falling. How many ambulances do we need? What kind of nets work best? Does the blue net work better than the red net? We're not really sure. We have to do that sort of study. Do fewer people fall once the fence is installed? Does that fence actually work? Does it need to be higher than it currently is? And then where do we focus that push away from the edge? So if we know that we want to do some public policy work, if we know that we want to actually make an impact in a larger societal way, well, where do we even focus that initial push? So we're about to start talking. I'll be throwing around a couple of terms, but let's start off with epidemiology and biostatistics. You'll be hearing those quite a bit. So before this year, when people asked me what I did, often they would think that I worked with skin, right? Because epidermis, but no, epidemiology is a little bit different. I would normally describe it in this very basic way, saying that epidemiology is the study of how diseases work in communities. So Wikipedia does have a little bit of a different definition, and they just throw a little more science into it. The study of the distribution, patterns, and determinants of health and the disease conditions in defined populations, which is really just a fancy way of saying it's really the study of how diseases work in communities. One thing that's important is that we can talk about epidemiology of both infectious diseases, which are things like COVID, as well as the epidemiology of chronic diseases, which are things like cardiovascular disease. There's also biostatistics, which is another field of expertise of mine. And so biostatistics is, at its most basic, the development and application of statistical methods to the biological sciences. Sometimes when you study statistics, it is very much in the service of lab sciences, right? And so there's an expectation that when you repeat an experiment over and over again in a lab, you are going to get the same results. But it doesn't really work that way in biological systems. We have a certain amount of understanding, but we don't understand everything. So for example, you could give that cholesterol lowering medication to 1,000 people. And for some proportion of that 1,000 people, it's going to work really, really well. For some proportion of that 1,000 people, it's not going to work at all. And for a bunch of people in the middle, it's going to work well enough to do its job. But because we don't really understand all of the underlying mechanisms of how that drug works exactly, we really need to have a different kind of math, a different kind of statistics to understand that distribution that's inherent in biological systems. So, go ahead.
Moment. Yeah, so going back to epidemiology, can you clarify for us the difference between maybe your job and the job of a doctor or a scientist in a lab, studying the disease itself? So what type of tools do you need and how does it differ from those types of professions?
That's a really great question. So I think that those are all different pieces. So a medical doctor, you go to medical school, you come out a medical doctor. Very often you will be practicing. It is very much of an individual patient focus. I am not a medical doctor, so there are limits to my knowledge here. You are really thinking about what is going to work best for your particular patient. You have a specialty perhaps that you've studied where you might be studying the results of epidemiological studies in order to inform your decision making for your patients. Now, there are some doctors who are also epidemiologists. There are some doctors who also run those kinds of studies that we're talking about. But for the most part, when I think of doctors and people who practice medicine, so I'm including here physician's assistants, nurses, other people who work in the medical field, it is very much about it. If we think about the cliff model or the cliff analogy, it's the ambulance and sometimes the net, right? It's the people who are really coming in. Oh, you're already sick. Oh, you're getting sick. I am going to save you from getting worse, right? So somebody who works in a lab, that's a really different set of skills. Not my set of skills. In fact, I think one of the reasons why I ended up in public health was because I did not have a great time in organic chemistry lab in college. It was, I'm not a good baker, right? Like you have to have a very, very fine motor skills and a very good ability to follow all the directions exactly in the right order. And I always felt like I was in Harry Potter's potion class, right? Like my thing would just bubble up and do the wrong things. Anyway, so if you're a lab scientist, you also may have a training in epidemiology, and I'll actually be talking about all the different the places you'll go for people who I've gone to school with. One of the places that they land is running labs or working in labs. You need to have a different set of skills for that. I would say that that's more foundational sciences. So I'm not sure what the interest level is in your class, but that's going to be people who are bio majors, microbiology majors, people who might want to do a master's or a PhD in biological sciences, people who might have a more of an interest in biochemistry. I have one friend who is a bio major in college with me, and she's working at a pharmaceutical, she works in the pharmaceutical industry for the last 15 or so years, right? So where she is an expert in this one particular machine that, I don't remember if it's a PCR machine, but essentially something like that, where you have to learn all the basics, but then you pick an area where you specialize. So does that answer your question? Do you have more on that specific area?
To clarify for the students, I think that everybody understands, right? The purpose of, so an epidemiologist is looking at a community. How does this affect people on a larger scale or in a specific, separate community, and going forward from there? Okay, great. Thank you.
Yeah, I think that that's a great point, right? So epidemiology is studying the way diseases work in a community, and it's not very much about each individual person. I used to, with somebody that I worked with at the California State Department of Health, and he was like a real public health guy. He said, if you are saying about your work, well, it's all worth it to just save one person, you are not in the right field. Right? That is not public health. Public health is it's not all worth it to save one person. That's kind of like, that's a doctor thing. That's a medical field thing. But in public health, what we're really looking for is, what is the thing that's going to save the most people? What is the thing that we can do that allows us to use the resources to really help the largest sector of the community? All right, so now let me talk a little bit about just about my own journey, so you have a sense of where I've gone, where I'm coming from. So here we are in New York City together. I finished Flatbush in 1995. I went to NYU and was a double major there in neuroscience and English literature with a minor in computer science. And, that was a lot of fun. I had lived in New York a little too long at that point, so I took a year off and moved to Southern California to go and be a fellow for Hillel International. I worked at 3 different college campuses and encouraged people to join Hillel. That part of Southern California was quite literally about as far as you could get from New York City, both geographically and mentally. And I only made it there for about 11 months before I moved up to the University of California at Berkeley. That's where I did my master's in, I did a master's of science in epidemiology and biostatistics. And there my master's thesis was a critical review of mathematical models of theoretical HIV vaccines, trying to understand, what were the implications for behavior if we had HIV vaccines that were only partially effective. And so that, of course, is another set of discussion points that we can have today. I moved back across the country to Baltimore to go to the Johns Hopkins Bloomberg School of Public Health. That's where I did my PhD in infectious disease epidemiology. And there, my doctoral dissertation was about the impact of neighborhood level incarceration rates on HIV sexual risk behaviors. And that was just a really amazing experience. And I'm happy to talk more about just the overall, what is it like to get a doctorate, if people are interested in that as well. I thought it would be fun just to kind of go through my old classes and see just a smattering of the different titles. What are the different kinds of courses you could be taking if you too decide to do an epidemiology or biostatistics degree? There were a lot of biology, epidemiology, math, and statistics classes over the course of my lifetime. I love math and science, obviously, because just looking at some of these, I kind of wish I could go back to class. Epidemiology is not just about math and science, though. It's also very much about analytical thinking, taking the data that you are given and drawing inferences from it. So if you like, sort of logic puzzles, that is another great place to go. I was asked specifically to call out what my Flatbush experiences, have helped, how they have helped me in this journey. And I would say that really the fact that we had this really rigorous AP program was very influential. So I was able to take AP Econ, which interestingly enough, now that I have the ability to look back, because of all the statistics and all the models, that was actually a really good foundation class for me. AP Bio, of course, AP Computer Science, because all of this math and statistics certainly has a lot of programming that comes with it. AP Psychology, and then, of course, the class that you're teaching right now, Dr. Sutton, the Anatomy and Physiology class. So I did want to make sure I called out. So we talked about how you go to medical school. You become a doctor. That's usually what you end up doing. You go to public health school. These are the kinds of places that my friends and colleagues have ended up. So plenty of people at Hopkins still who are focusing on infectious diseases like COVID, like HIV, like measles. And you've probably read interviews with them or their op-eds in the paper. I have one friend who is studying genetic behavioral disorders in Sweden. A friend who is studying tobacco regulations and their impact on smoking behavior, a person who is a health services researcher and program evaluator at Children's Hospital in LA, a microbiologist for the California State Viral Labs, a RAND consultant studying the intersection of providing housing and how that impacts health, the Merck Director of Pharmacoepidemiology, which didn't really want to fit on my slide, but I made it. A couple of friends who are career scientists at the National Cancer Institute, the Food and Drug Administration, and the Environmental Protection Agency. A couple of friends who went into the CDC Epidemiologic Intelligence Service, or EIS, otherwise known as the Disease Detectives. And of course, the National Center for Health Statistics. A couple of us did end up there, including me. So this is where I'll start talking about NCHS, but I will pause here for questions about just that professional or that educational part of my journey.
Well, we're gonna save our questions for the end, they said.
Okay, that sounds great. All right, so let me tell you a little bit about NCHS, which is probably you have, while I'm sure you've heard of CDC by now, you probably have not heard about NCHS. NCHS is it is the principal health statistics agency for the nation, and that makes us a little bit different from the rest of CDC. But our mission is to provide statistical information, so that those health statistics I was talking about earlier, to guide the actions and policies that improve the health of the American people. It is incredibly important to us to lead the way with accurate, relevant, and timely data. And very importantly, in the graphic on the bottom, what we do is we provide information, health statistics on the whole nation's health from birth to death and everything in between.
I'm so sorry to interrupt. We have a question in the chat that I just saw. How long was each degree?
Good question. Master's degrees, especially at the professional level, I'm not talking about like a master's in English or a master's in biology. This is a master's in science and public health. That was 2 years. The PhD, you can go through it as fast as you like. I did it in 5 years, but I did also have a baby at the end. So, there's a little bit of a, maybe I took a little bit of extra time. But I certainly had friends who So when I did this, I also skipped a little bit of work experience in between, right? So I went to college. I took a year to kind of figure out where I wanted to go. Did my master's program, took 2 years to work and also figure out what I wanted to do next, and then went to my PhD, right? So by the time I graduated, I think I was 30, I think, something like that. But I certainly had friends who started at Hopkins in the master's program in epidemiology straight out of undergrad. Um, and then they did a 2 years of a master's at Hopkins, then continued on to the PhD within the same institution, and basically started their third year with us as second or third years, or maybe they started as a second year. So there are, if you know what you want to do, you can have a little bit of a time savings in there. I had less clarity, I would say, and needed to find my path throughout. But I would say if you talk to people who are in public health, very often there's not really a linear path. I'm actually doing a talk tomorrow. I'm organizing a session for college students doing a virtual visit at NCHS. And so all of our speakers are encouraged to talk about their path to public health. And I will guarantee you, we have 4 people talking. Not one of them will, none of those stories will be the same. And I will guess that none of them will actually have a very linear path all the way through to NCHS. Other questions?
We're good, thank you.
Okay. Great. So NCHS was established in 1960 as the nation's principal health statistics agency. It actually was a couple of other different agencies merged together. Our offices are in Hyattsville, Maryland, which you've also never heard of, but it's right outside of DC, and Research Triangle Park, North Carolina. And since 1987, we've been a part of the CDC, which is based in Atlanta, Georgia. And of course, the CDC falls under the whole big umbrella of the Department of Health and Human Services. So we have a number of surveys and different programs that exist at NCHS. I will not give you the full detail. I could probably talk for an hour about each of these. But just like I said, from birth to death and everything in between, the National Vital Statistics System has been getting a lot of attention lately. This is where we collect all of the mortality statistics, all the statistics about deaths. And they are really an amazing group. They also, this is also the organization or the group that also does the birth statistics. So looking at fertility rates and how they change. The National Survey of Family Growth over there in the purple is a survey that actually helps us understand changes in those birth rates, because there's not a lot of information that actually comes in on birth certificates. The 2 surveys in the middle, the National Health Interview Survey and the National Health and Nutrition Examination Surveys, those are nationwide representative surveys that give us important information, like if you wanted to talk about the obesity epidemic in the US, those data are coming from people actually going to get measured in the same way all across the country as part of the NHANES, that's the green one. If you want to talk about whether or not people, how many people have anxiety or depression, those numbers are going to come out of the National Health Interview Survey. The national healthcare surveys are a little bit different. Those are surveys of doctors and hospitals and ambulatory care centers that help us understand things about, how many types of a certain procedure are happening, how many knee replacements are happening, or how many emergency department visits are happening where there's also an opioid prescribed. So those are the different kinds of data that we collect. So I also wanted to just do a quick word cloud here. I've had a chance to publish lots of papers in lots of different areas, and this word cloud was built off of my Google Scholar citations, and pretty clearly, I think, shows that the last 10 years I've spent publishing data from the National Health Interview Survey, which of course those estimates are going to be about the entire United States and provides estimates on lots of different health topics for the entire country. This is, according to Google Scholar citations, my most highly cited paper, which is very exciting. And this is about e-cigarette use among adults, based in data collected in 2014. And these were some of the first data to come out about a nationally representative sample. So where you can really scientifically say, this is what is happening in the country. These were some of the first data to come out about e-cigarette use. And we broke these down into a number of really simple questions. Who has ever used e-cigarettes by age, sex, and race? Who was currently using e-cigarettes by the same? Whether you were more likely to have used e-cigarettes if you also smoked cigarettes, or if you had tried to quit smoking cigarettes. So this was a very exciting paper to work on. And actually, it's a really good example of what my scientific publications looked like for the first part of my career at NCHS. But actually, for the last 2.5 years, I have transitioned to more of a supervisory managerial role. And now I'm actually leading the team that's putting together this report, which is called Health United States. Health United States is actually kind of exciting. It's a congressionally mandated annual report from the Secretary of Health and Human Services to the President and Congress. So I don't know how many of you ever thought that you're sitting there in the room and then in 25 years you'll be writing things that get sent directly to the president. It was kind of cool. I had to address all the FedEx envelopes and I had to write to the president, and the address was the White House. It's kind of a neat thing. But this has actually been, this report has been going on since 1974. This legislation was from 1974. So we started sending the first of these reports in 1975, which is actually before I was born. So that's always fun to take over the leadership of something that has been around for longer than you have. And this particular report is actually technically 4 different reports. So we provide information to the president and Congress about healthcare costs and financing, health resources, utilization of health resources, and overall the health of the nation's people. So, like I said, we have been doing this report since 1975, and so periodically over the course, we have been taking steps to update it to make it better, make it better suit the needs of the president and Congress and our other readers. And so these days, the issue is that the way that people look for health information, health statistics, and the way that they use health information and health statistics has pretty fundamentally changed since 1975. And so we are trying to modernize the report and ensure that we can get Congress the statistics that they need to make effective policies that impact health. So I want to just finish up on my slide part today with one really fundamental way that Health US examines the health of the nation's people. And that's called life expectancy. Not sure if you are talking about that in your classes. And this is a really fundamental health measure. And it's always the very first graph in the Health US report. So what is life expectancy? It is a population level summary measure of death. So you end up with one number that can be used to describe the health status of an entire population. And because you have one number, it also can be used to compare groups, compare between different groups, or to compare the same group over time. And that's what we're doing here in this particular graphic. Right? So the average life expectancy at birth, and also life expectancy at birth is a baby born in this year. How long would you expect them to live based on kind of what's going on with mortality at the time? So the average life expectancy at birth in 1900 in the US was 47 years. And then throughout the first half of the 20th century, life expectancy at birth kept increasing, as you can see in the graphic here. We had improvements due to sanitation, because of hygiene. We had the introduction of antibiotics and the implementation of vaccination programs. So these led to decreases in death rates for infectious diseases, which were among the leading causes of death in general, but especially among children. So by 1950, the average life expectancy at birth had actually increased by about 20 years to 68.2. So the age at which people die is an important contributor to life expectancy. When people die at younger ages, that reduces the life expectancy. So in recent years, that trend towards increasing life expectancy has actually reversed. So between 2014 and 2015, life expectancy dropped for men and women. And the decline continued for men into 2017, but actually halted for women. So these reports that NCHS and Health US put out on life expectancy led to these different news stories about the life expectancy drop, as well as additional research on the kinds of factors that may have led to the decline, and lots of ideas about what could be done about it. NCHS and Health US were able to meet the needs of policymakers, the press, and the public to help each of them understand more about the changing health of the nation. So that is it for my slide presentation, but I would love to be able to answer questions at this point.
We had one question in the chat. How has coronavirus affected your job, or has it maybe?
That's a great question. So coronavirus has affected my job in a couple of different ways. I am not, like I said before, I am not working directly on coronavirus at all. However, what has happened across all of CDC, certainly at NCHS, and then of course across all of CDC, is that we are doing, they need a lot of extra help, right? So we have CDC staff who are going out to the states. Initially, we had people who were actually going out to the airports and doing screenings back when people were flying on airplanes. But we certainly have had lots of data people going out and helping with data, trying to understand, create dashboards for where hospitals can feed their information in so that we can find out real time how many hospital beds are left, or where there are ventilators needed, or where there is PPE needed. So those are the kinds of things that people on my team have been going off and doing. Those are the kinds of those are the kinds of things that NCHS has been doing. Another thing that has been very important for us is you're seeing, really daily updates for the US about the number of people who are dying from coronavirus or coronavirus related illnesses. So those data are coming out of NCHS. And, one thing that it means for me is that a lot of resources are going towards that very, very specific work. And so obviously it's incredibly important and something that we need to be taking care of right now. And so that's where a lot of the focus is. But then, we have less focus and less sort of mental ability to deal with some of these other pieces. The last way that it's, I think, really going to impact me is it's going to impact my work in the decisions that we make. So this Health US report is an annual report, right? And the most recent one that you can find on the web is called Health US 2018, and it references data through 2017. So we're winding up quite an important year for health in the United States. But what is Health US 2020 going to have in it? Because the data that we collect is just a little bit too far behind. So I'm really trying to think pretty hard about how we change what we report to Congress. Because to be honest with you, to give something to the president and Congress next year that says, here's Health US 2020, we don't know what happened in 2020. Who knows? Who knows what happened in 2020? And that I think that won't quite work. So we're really trying to figure out how to address that.
Thank you. Our bell just did ring, so
Oh no!
we have to leave. But we did, for whoever can stay, we had one last question.
Sure.
Which is, how do you balance the, public health, putting in the position, the fences and the gates and all of that, and also allowing people personal freedom?
I think that's a great question, and obviously one that's been coming up quite a bit. And I think that there are some important differences. And again, I will say this as a personal citizen with experience and not as a CDC employee. I think there are some important differences between chronic disease and infectious disease when it comes to personal freedoms. Because for chronic disease, ultimately, I guess there is a certain amount of personal choice that you can make, a personal choice that you can have, that because your actions and your behaviors impact you, right? But infectious disease is a little bit different. Because, when you think about vaccination, right, there is a reason that we have had vaccination mandates in schools. It is because in order for infectious diseases to be stopped, things like measles, things like polio, in order to eradicate or eliminate those diseases, you have to prevent the disease from gaining a foothold. And the problem is that not every person is able to get a vaccination, right? There are people who are, for immune deficiency reasons or allergy reasons, unable to get that vaccination. So it is your responsibility. And I would say this is another place where Flatbush becomes an important piece of my thinking here. Kol Yisrael Arevin Zeh Lezeh, right? That's really important. It is my responsibility as a Jew and a human being to help protect you, right? And so it is my responsibility to do what I can to prevent infectious diseases from spreading. So if you are while I understand personal freedoms, there is also an element of needing to be a part of a community and to provide the safety in numbers that being part of a community can involve. So I think that was a great last question. So thank you very much for it.
We actually have now students coming in, I think, for the next class. So
okay,
we have to wrap
all
up.
right.
I want to thank you on behalf of the class and the school and my students. That was really wonderful.
Thank you. Thank you both.
Thank you.
Hi,
It was-
Renee.
Thank
Thank
you.
you. That was amazing. So nice
right.
to see you.
Yes,
You're
it was-
so inspirational.
Oh, thanks. Thanks, Deborah. It's nice to see you too.
Really? Oh my gosh. I'm
Dr.
in
Sutton?
awe.
Oh, oh, it's just the work that we do every day on behalf of the American.
Wow.
So
Wow.
thank you for having me.
Unbelievable. Thank you
And,
for taking the time out. Really
oh,
good to see you and continue
right.
your great work.
All right. Well, thanks you. And thanks very much, Frida. And it was a pleasure working with you.
Yeah, it was really a treat to have you. I'm so happy that the students are all out now, but you know that they got to see, it happens to be a class of young women, so that they get to see you in this position, you know, really, you're writing letters personally to the president, very empowering. So thank you. so much. Really
Good. Please feel free to stay in touch if you need anything from this end.
Sure. Yeah, that's great. Okay, thank you so
Okay.
much. Well,
All right. All right. Thanks. Bye.